You open a new tube of prescription medication, right? You unfold that giant, densely printed tissue paper warning label that folds out like a map.
Oh, yeah, the one nobody actually wants to read.
Exactly, but your eyes immediately lock onto the word atrophy, printed in just bold black letters.
Right.
And it's a terrifying moment. I mean, you're holding this medication because you're trying to fix a painful medical problem, not, melt your own skin off.
Right, which makes complete sense.
But what if the very medication warning you about skin thinning is actually the only thing that can stop it from happening?
It feels like a massive contradiction, doesn't it?
Yeah, it really does.
And when that medication is a highly potent topical steroid prescribed for the vulva, which is arguably one of the most exquisitely sensitive parts of the human body, the anxiety just spikes.
Oh, absolutely.
Because we are conditioned to view medical treatments as this comforting intervention. Applying something that explicitly threatens to degrade your tissue, it feels instinctively wrong.
Which brings us to the core mission for today's deep dive. We are looking directly at whether long-term topical corticosteroid use for vulval skin conditions, specifically autoimmune conditions, like lichen sclerosis, whether it actually causes secondary mucosal thinning and localized dryness.
Right.
Because if you are someone staring at that warning label, weighing the risk of permanent skin damage against the immediate relief of your symptoms, you need to know what is actually happening at a cellular level.
Yeah, and the hesitation is completely irrational based on general medical advice.
Right.
But the clinical reality in this highly specific area of the body, it paints an entirely different picture.
Really?
Yeah. The data we have now, and this is drawing from decades of dermatological and gynecological research, official national guidelines, long-term patient tracking it, shows us that the fear of steroid atrophy in this context is based on a fundamental misunderstanding of what is actually destroying the tissue.
Okay, so let's pull that apart. The reigning fear is steroid-induced atrophy. But if we are talking about lichen sclerosis, the disease itself is a chronic, severe inflammatory condition. Like, the disease is what causes the thinning, the scarring, the loss of elasticity, and literal erasure of normal anatomy.
Exactly. That is the crucial paradigm shift here. The disease is the fire. The steroid is the water putting out the fire.
Okay.
So when a patient with lichen sclerosis feels their skin becoming incredibly fragile, prone to tearing like wet tissue paper, they often look at the steroid they've been applying and blame the medicine.
Which is a natural conclusion.
Totally. But biologically, what they are experiencing is the unchecked progression of the autoimmune disease itself, because the inflammation just hasn't been adequately suppressed yet.
Wait, I need to stop you there because I can hear the skepticism for people listening already.
Oh, sure.
If you take a medication like clobetasol propionate, which is classified as a super potent steroid, right?
Right.
And you apply it to your forearm every day, it will thin that skin. It will cause atrophy.
It absolutely will.
So how is it biologically possible that applying that exact same super potent chemical to the highly sensitive tissue of the vulva for years doesn't melt it away? I mean, that goes against everything we were taught about steroids.
It's a brilliant question. And the answer lies in the unique histology of the vulva itself.
Yeah.
The tissue we are talking about, specifically the modified mucous membranes of the labia minora and the periclitoral area, is fundamentally different from the keratinized skin on your forearm or your face.
How so, though? I mean, a skin cell is a skin cell, isn't it?
Not at all, actually.
Okay.
So the epidermis on your arm has this thick, tough outer layer called the stratum corneum, built to withstand the outside world, and it turns over relatively slowly.
Okay.
The modified mucosal tissue of the vulva lacks that tough outer keratin layer, which is why it feels so sensitive in the first place.
Right.
But in exchange, it has a remarkably rapid cellular turnover rate and an incredibly rich vascular supply. It heals and replaces its cells much faster. Yeah, and because of this distinct biological architecture, it is virtually immune to the specific mechanisms that cause steroid-induced atrophy in standard skin. It just doesn't respond to the steroid by shutting down collagen production the way your forearm would.
So it basically has a biological superpower against this specific side effect.
It really does. There was actually a landmark study by Bradford and Fisher, and they followed 129 patients for over 6 years.
Oh, wow.
Yeah, and they didn't just ask patients how they felt, They physically measured the tissue over time. And they proved that long-term continuous treatment with potent steroids was not only safe, but it actively restored normal architecture.
We restored it?
Yes. 6 years of super potent steroid use and 0 cases of steroid-induced atrophy.
That's incredible. So if this specific tissue is essentially immune to the side effects that plague the rest of our skin, that completely changes the math on the dosage required, right? You aren't forced to tiptoe around the condition anymore.
Exactly. You can't tiptoe around lichen sclerosis.
Right.
You need immense medical firepower to stop the autoimmune attack.
So we're not talking about like over-the-counter stuff.
No, we were far beyond the mild 1% hydrocortisone you might buy for, a mosquito bite. The absolute gold standard of care requires those super potent formulations like clobetasol propionate 0.05%, or at the very least potent ones like mometasone furo 0.1%.
Right.
You have to hit the inflammation hard enough to achieve three things: stop the agonizing itch and pain, normalize the skin texture, and halt any further scarring.
Well, I want to get into the physical realities of applying this because there is a massive chemical distinction in the formulations that doctors prefer, right? Like, according to the sources, there is a very strict preference for prescribing ointments over creams.
Yes, absolutely.
But to someone standing in a pharmacy, a cream and an ointment just sound like two different words for lotion.
Clinically, the difference is monumental,
Yeah.
and it all comes down to water. Yeah. Creams are oil and water emulsions. They feel light, they vanish into the skin, which, let's be honest, people generally prefer cosmetically.
Sure, nobody wants to feel greasy.
Exactly. But because they contain water, they are a breeding ground for bacteria.
Oh, so they have to be packed with preservatives to keep them stable on the shelf.
Precisely. They require preservatives like parabens. They often need alcohol derivatives like propylene glycol to act as a stabilizer, and sometimes they even include fragrances. Now imagine taking propylene glycol and rubbing it into highly inflamed, microfissured, autoimmune-ravaged mucosal tissue.
That sounds excruciating.
Yeah.
I mean, putting a water-based cream on an autoimmune flare-up is like trying to put out a grease fire with water. The preservatives end up acting as like an explosive irritant to the raw skin.
Right. It triggers an intense inflammatory cascade of its own, often leading to severe burning, stinging, and allergic contact dermatitis.
Oh, wow.
Ointments, on the other hand, are strictly lipid-based. They are pure oils and waxes, usually a petrolatum base. Because there is zero water, there is zero need for preservatives. No parabens, no propylene glycol.
So they just don't irritate it the same way.
They don't sting when applying to open fissures at all. And they form a physical protective barrier over the damaged tissue that locks in moisture while delivering the steroid.
Well, that brings up a massive communication breakdown between the prescribing doctor and the patient, I think, because doctors and pharmacists have this reflex to tell patients to apply topical steroids sparingly.
Yeah.
It's written on the box, it's repeated at the pharmacy counter, but if a patient is already terrified of the medication and they are told to use it sparingly, they're going to use a microscopic, almost molecular dab of this ointment.
And that is the problem. The word sparingly is arguably the most damaging piece of generic advice given to patients with lichen sclerosis. It basically guarantees undertreatment. We have to look at the actual math of the dosage to understand what a proper application looks like. So a standard 30-gram tube of this ointment is designed to last a patient about 3 months during their initial active daily treatment phase.
Wait, 3 months for 30 grams?
Yep.
That means if your tube is sitting in your bathroom drawer 2 years later and it's still half full, you are vastly undertreating the disease.
You aren't even making a dent in it. Once a patient reaches the maintenance phase, where they are applying it less frequently, that same 30-gram tube should last about 6 months.
Okay, so what does a proper application actually look like then?
The goal is to apply a thin, glistening film, often measured as a fingertip unit, over the entire affected area. You cannot just dab it onto the specific white spots or the areas that actively itch today.
Right, because the disease is everywhere.
Exactly. The autoimmune disease affects the entire anatomical region microscopically. Patients need to systematically rub the ointment into the medial labia majora, both sides of the labia minora, the perineum, and the perianal skin.
Wow, so really the whole area.
Yes. And you rub it in with a bare finger until it is absorbed. Using a cotton swab just traps the medication in the cotton and creates unnecessary friction on fragile skin.
Which, I mean, that opens the door to a really harsh reality here. We know the tissue resists atrophy. We know the super potent ointments are safe and necessary. So why do so many patients feel like their treatment is failing?
That's the million-dollar question.
Because they go back to the doctor, they're miserable, dealing with ongoing symptoms, assuming the steroid just stopped working.
The primary driver of treatment failure in these conditions is actually human nature. It's non-compliance.
Non-compliance?
Yeah, think about it. A patient diligently applies the ointment for 4 weeks. The agonizing itch finally subsides. The skin looks a bit calmer. They think, I'm cured, and they put the tube away.
Oh.
Or, the chronic fear of that warning label finally wins out, and they start skipping doses, trying to protect themselves from the phantom threat of atrophy.
It's the exact same psychological trap as blood pressure medication, isn't it?
Oh, completely.
You take your pills, you have a totally calm, stress-free week, your blood pressure reads normal, so you decide you don't need the pills today. But the underlying mechanism, the hypertension, or in this case, the localized autoimmune attack, is still there, just silently working in the background.
Exactly.
Because lichen sclerosus is incurable. It requires lifelong management.
And lifelong management is a really tough pill to swallow, especially when you feel completely fine. Why apply a potent steroid twice a week, every week, for the rest of your life if nothing itches?
Right. So why do they need to?
This is where we have to talk about malignant transformation.
Okay.
Uncontrolled lichen sclerosus carries a 0.3% to 4.9% risk of developing into squamous cell carcinoma, which is a very serious vulval skin cancer.
Oh, wow. So that is the ultimate so what of this entire discussion. The maintenance isn't just about stopping a future itch, it's literal cancer prevention.
Exactly. When tissue is constantly inflamed, the cells are under perpetual attack. The body is constantly forced to rapidly divide and replace damaged cells.
Right.
That chronic, high-speed cellular turnover dramatically increases the likelihood of genetic mutations.
Yeah.
Specifically in genes like P53, which normally protect us from cancer.
Oh, I see.
So the long-term, twice-weekly application of the steroid suppresses that chronic inflammation. It gives the cells a stable environment. It is essentially your primary shield against that malignant transformation.
That is so important to understand. So we have definitively established that the steroid is the protector, not the destroyer. It doesn't cause mucosal thinning, and it is vital for long-term health.
Yes.
But we still have to answer the second half of the core question for today's deep dive. If a patient is doing everything right, they are using their clobetasol, they are applying the right amount, they are maintaining their schedule, but they are still experiencing severe localized dryness, fragility, burning, and painful sex.
Right.
If it's not the steroid causing it, what is?
This is where clinical detective work becomes absolutely essential. If a patient is compliant with their steroid regimen, but complains of persistent dryness, burning, and dyspareunia, painful intercourse, the clinician should not blame the steroid. And they shouldn't just assume the lichen sclerosus is flaring up.
So what should they do?
They need to investigate secondary diagnoses. You could have a well-controlled autoimmune condition and simultaneously develop a completely separate issue in the exact same tissue.
Two things can be true at once.
Exactly.
And the first major culprit that stands out in the sources here is GSM, genitourinary syndrome of menopause.
Yes, formerly known as atrophic vulvovaginitis. GSM is fundamentally an estrogen-depleted state. We naturally associate it with menopause, sure, but it also occurs after surgical removal of the ovaries or even during prolonged periods of breastfeeding.
Interesting.
Yeah. Estradiol, the primary estrogen, does incredible work in this area of the body. It maintains the glycogen stores in the tissue, which feed the good lactobacilli bacteria, which in turn keeps the vaginal pH perfectly acidic.
So when the estrogen drops, that entire microecosystem just collapses.
It collapses completely. The tissue loses its elasticity, the blood flow decreases, the skin turns pale and friable, and the natural moisture barrier disappears.
Wow.
It causes a profound, deep burning and severe dryness. So to a patient, it feels like their lichen sclerosus is spiraling out of control, but the biological root cause is entirely different.
And what is fascinating is the treatment for GSM directly contradicts the myth we debunked earlier about hormones and autoimmune conditions.
Oh, right.
Because topical estrogen, like an estradiol cream, does absolutely nothing to treat the autoimmune inflammation of lichen sclerosus. But if a patient has concurrent GSM, they desperately need that vaginal estrogen prescribed alongside their steroid.
Exactly. It's a dual therapy approach. You use the potent steroid to suppress the rogue immune system on the vulva, and you use the localized estrogen internally to restore the moisture, the glycogen, and the structural integrity of the tissue caused by the hormonal drop.
But hormones aren't the only secondary issue that can mimic an autoimmune flare, right? What happens when the microscopic skin barrier is compromised?
You open the gates to superinfections.
Ah.
Patients with underlying skin conditions are highly susceptible to recurrent candidiasis, which is a yeast infection, or bacterial vaginosis.
Oh, I see.
And a lingering low-grade yeast infection often doesn't present with the classic, obvious symptoms. It can present purely as an intense, raw, burning sensation, deep redness, and extreme localized dryness because the yeast thrives in the microfissures of the compromised skin.
Wow. So if a patient goes to the doctor complaining of a flare-up and the doctor just says, use more steroid, without actually doing a swab, they are essentially pouring fuel on a fungal fire.
They absolutely are. They are suppressing the immune system's ability to fight off the yeast, making the infection infinitely worse. This is why testing is mandatory when symptoms change or resist standard treatment.
Then there's a third culprit, which I think is almost the most insidious because it comes from inside our own bathrooms.
Oh yes, irritant contact dermatitis.
Right. People think they're doing the right thing by staying meticulously clean, but they are actually chemically stripping their own skin.
The vulval skin has a delicate, slightly acidic mantle. When patients use standard bar soaps, bubble baths, fragrance body washes, or even just wear daily panty liners, they're inflicting chemical and mechanical trauma.
Because of the ingredients, right.
Exactly. Soaps contain surfactants. Their literal chemical job is to bind to oils and wash them away. When you use that on skin that is already struggling to maintain a moisture barrier, you strip away every natural lipid it has.
Ouch.
Yeah. The result is microabrasions, severe dryness, and secondary thinning that perfectly mimics the atrophy patients are so afraid of.
Which brings us to a massive, under-discussed tool in the dermatological arsenal, emollients. Products like Dermal 500, Deprobase, or Zero Base. People tend to view them as just heavy lotions, but they act quite differently.
Emollients are active treatments. They need to be used as a total soap substitute.
Wait, so you don't wash and then put it on?
No, you do not use them after you wash. You use them to wash.
Oh, wow.
Yeah. They lift dirt and irritants away from the skin without stripping the natural lipids. In fact, they deposit a protective lipid layer behind. This barrier is critical because it protects the raw skin from highly acidic urine, which can cause excruciating pain on contact.
But there's a chemical conflict here that patients often aren't warned about. You cannot apply an emollient and a topical steroid at the exact same time.
You really can't. If you apply your steroid ointment and then immediately slather an emollient over it or vice versa, you compromise the medication.
How so?
The heavy lipids in the emollient create a physical blockade on the skin cells, preventing the steroid from binding to the glucocorticoid receptors in the tissue. Or it simply dilutes the potency of the clobetasol.
So what's the workaround?
The clinical rule is to leave an absolute minimum of 30 minutes between applying the two. A very practical strategy is to apply your potent steroid ointment at night, right before bed, so it has hours to absorb undisturbed.
That makes a lot of sense.
Yeah, and then rely heavily on your emollients throughout the day, using them to wash and to reapply a protective barrier every time you use the toilet.
Okay, so when we pull all of these complex threads together, the answer to the fear that drives so much anxiety is startlingly clear. Does long-term, properly applied topical corticosteroid use cause secondary mucosal thinning and localized dryness in vulval skin conditions?
No.
No. In fact, it is the only mechanism that reliably prevents the architectural destruction caused by the disease itself. Because the specific mucosal tissue of the vulva has an incredibly rapid cellular turnover rate, it is uniquely protected against the steroid atrophy that occurs elsewhere on the body.
Exactly.
This means treatments like clobetasol are safe for lifelong maintenance. And crucially, if you are experiencing severe ongoing dryness, it is a massive red flag that something else is happening. It isn't the steroid's fault.
Right.
It is almost certainly a secondary diagnosis, whether that's a hormonal crash from GSM, an undetected yeast infection, or harsh soaps chemically burning the tissue.
The ultimate lesson here is the danger of generalized medical communication. Those bold warning labels are written for the average person applying hydrocortisone to their arm. They are not written for the highly specialized, remarkably resilient mucosal tissue of the vulva fighting an active autoimmune war.
Right.
This is why having an annual follow-up with a specialist who understands this specific biology is non-negotiable. They need to check that your dosage matches the microscopic reality of the disease, rule out secondary infections, and adjust your routine so you aren't just surviving the condition, but actually living comfortably.
Think about the weight of that warning label. Just think about how many people right now are sitting in their bathrooms, staring at a tube of ointment, and choosing to endure agonizing pain or allowing irreversible anatomical scarring to happen to their bodies simply because a generic pharmaceutical warning wasn't nuanced enough to explain the difference between the skin on their arm and the skin on their vulva.
It's heartbreaking, really.
It is. It is a stark reminder that when medical communication lacks precision, it doesn't just cause anxiety, it causes physical harm. So the next time a generic medical warning makes you second-guess your prescribed treatment, ask yourself, What biological reality is this label leaving out?